Welcome to tonight's Wu University's webinar, Focus on the Lids for OSD Success with Dr. Melissa Barnett. I'm your host, Dr. Jennifer Stewart. It's my great pleasure to introduce Dr. Barnett tonight. She's a world-renowned key opinion leader recognized for her expertise in specialty in scleral lenses, dry eye disease, keratoconus, and presbyopia. She's authored more than 275 articles and books, serves on several industry boards, and delivers over 200 lectures. Her work has been featured in medical journals, professional magazines, as well as consumer publications such as Bloomberg, Prevention Magazine, and Good Housekeeping. She's energized by her passion for helping people improve their lives by optimizing their vision, health, and wellness with a customized approach. She's most proud of being awarded the inaugural Thea Award for Excellence in Mentoring by Women in Optometry and was granted the Most Influential Women in Optical by Vision Monday. She's a director of optometry at the University of California, Davis, and is the host of the Clearly KC podcast. She advocates for elevating eye care through technology and her influence on the profession. Welcome, Dr. Barnett.
Well, thank you so much for the kind welcome, and thank you all for attending tonight. Here you can see my disclosures, and I would love for you to listen to the Clearly KC podcast. It's with the National Keratoconus Foundation. Let's continue the conversation on social media, and eye care is so exciting, and this lecture is going to be chock full of breaking new information. All financial relationships have been mitigated. If you have any questions, send me an email, drbarnett@ucdavis.edu. So tonight we're going to talk about focus on the lids for OSD success. And this is right now, August 23rd, 2023. Such an exciting time. And I'm saying the date specifically because things are rapidly changing. And in the next month, 1 month, it's going to be new information of how to get some of the things that I'm talking about tonight. So super timely, super fun. We're going to talk about various different topics, some more than others. And I have this new theory now. So I've been practicing for about 22 years. And when I go into an exam room, and any exam, so it could be a specialty contact lens, like a scleral lens, it could be a patient with dry eye, I'm looking at the patient from across the room. And why I'm doing that, why I'm taking that global view, is that I've learned that I can see so much. I can appreciate if their eyes are red, if they're injected, if there's asymmetry, if their eyelids perhaps have asymmetry, or if just looking at their whole body, looking at their fingers, for example, if they have rheumatoid arthritis. And this view's really helped. Prior to diving into that slit lamp exam, taking a look just at the whole person and the eyes is really helpful when I'm seeing patients. So here are some really nice images that came from the CLEAR report, and this was through BCLA. And here I want to point out the meibomian glands. I think these are just wonderful visuals. I'm a very visual person. And you can see the meibomian gland orifices here, and the gray line. Oh my goodness, had quite a conversation today about with a patient to avoid makeup on that line. And we all know the tear film and the beauty of the tear film. I hope that I can get all of you to appreciate how beautiful and amazing that tear film is. And we know the different layers of the tear film. So the lipid layer prevents the tears from evaporating between blinks. The aqueous makes up the majority of that tear film, and the mucin helps spread the tears across the surface of the eye. And I've been actually talking to my patients about tear film homeostasis, or that natural balance, that beautiful balance of the tear film, and they really understand it. So I would encourage you to talk to your patients about the tear film. The patient I just mentioned from today, who had so much makeup on her lower lid, had a horrific tear film. And I was telling her it's like a dirty windshield and having to clean it all day long. And to avoid makeup, and we talked about different products that could perhaps help a little bit better. And meibomian gland dysfunction is a major contributor to the evaporative etiology of dry eye disease. In 86% of patients with chronic eye discomfort, it's due to meibomian gland dysfunction. And just think about all of the digital devices that we're using every single day. When I lecture to audiences, and just think in your head, how many digital devices are you using a day? This could be your electronic medical records, your phone, your home laptop or computer. And then I was informed also that my watch, it also counts as a digital device. My Peloton also, think about all the things that you have. And so because dry eye is a multifactorial condition, we have aqueous deficient, we have evaporative, but we have many, many patients that have a mixed mechanism. It's so incredibly important to evaluate the eyelids and to treat that meibomian gland dysfunction. So here you can see the evaporation when evaporation exceeds the total tear supply, it leads to this desiccation stress or dryness, and which then in turn leads to tissue damage, inflammation, and it's this vicious cycle. I will have to say we have to include allergy. I'm here in Northern California, I think one of the worst allergy places, although we all say that, but really we have so many trees. We have allergies all year round. Many people who come to Davis say, oh, I didn't have allergies until I came here, myself included. And so that is something, we have meibomian gland dysfunction, we have blepharitis, we have Demodex, and we have to think about this cycle of inflammation. Now, at least I will say 38 million people in the US are affected by dry eye disease. Only 18 million people are diagnosed with dry eye. I'm saying this because I think these numbers are so low. We have to rule out dry eye in every single patient, just like we have to rule out keratoconus in every single patient. And 1.2 million people with dry eye are treated with a prescription medication. So just think about that. We have 38 million people who are affected by dry eye. We know that dry eye significantly negatively affects quality of life. It affects work productivity. It significantly affects a person's quality of life. And so few, 1.2 million people are treated with a prescription medication. And most prescription medications target either tear production or inflammation. So breaking news, you might have heard about MIBO, which is, and I'm still practicing here, perfluorohexyloctane. I'm going to stand in front of a mirror and say it 100 times, ophthalmic solution, which is a semi-fluorinated alkane. And it was recently approved by the US FDA for the treatment of the signs and symptoms of dry eye disease. So the reason why MIBO is so unique is that it directly targets the root cause of most dry eye disease, which is evaporation. And evaporation is that core mechanism for dry eye. So it's the first prescription eye drop ever designed to target evaporation. So here is a little bit of additional information. So the drop size is unique. It's a very, very tiny drop. So compared to a typical drop size of 40 to 50, it's 11 microliters. So it's super small. It has a very long residence time on the ocular surface. So it can last up to 6 hours compared to, say, think of an artificial tear that's very brief that lasts just a few minutes. It has a very low surface tension, so it's rapidly spreading over the ocular surface to lubricate that surface, and it forms a film-forming properties. Unlike, say, other eye drops that have a high surface tension, which hinders or reduces spreading. And it is also preservative-free, and it's a single ingredient with minimal side effects and blurring. So I will go into some studies in just a moment here. So here you can see, compared to a saline, that MIBO actually inhibited the evaporation of saline by about 80%, and it displayed superior evaporation inhibition compared to other leading eye drops. There are 2 phase 3 studies, Gobi and Mojave, that were very repeatable and reliable. These were multi-center randomized double-masked studies comparing a hypotonic saline of 0.6% compared to now what we have as MIBO. And this looked at the signs and symptoms of dry eye disease associated with meibomian gland dysfunction. And all patients included in the studies have meibomian gland dysfunction. So here you can see adults who are 18 or older were included in the studies. Patients were given either meibo or hypotonic saline. And the primary outcomes was the change in total corneal fluorescein staining with that classic NEI scale at day 57, and then the changes from baseline in the visual analog scale dryness, so 0 to 100, are your eyes dry, score at day 57. Secondary outcomes, which are really clinically relevant here, is the change in the VAS dryness at day 15, because we want everything to work quickly for our patients and also work very well and safely. And the change in total corneal fluorescein staining at day 15. So the safety outcomes were looked at: the ocular, non-ocular adverse events, best corrected visual acuity, slit lamp exam, IOP, and dilated exam as well. So here you can see additional details about the studies. You can see the males and females, again, the meibo compared to the saline in the Gobi, and then meibo compared to the saline in the Mojave studies. You can see that there were a wide variety of patient backgrounds, ethnicities, races included in the studies. So here, looking at the primary endpoint, there was improvement with the meibo in both the signs and symptoms. So you can see an improvement in the total corneal fluorescein staining at day 57, again, primary endpoints here. And then a change in and an improvement in the VAS, visual analog scale, at day 57 as well in the meibo group. Very repeatable studies, very reliable studies. So the FDA actually used the two studies in order to approve this new product. And the secondary endpoints, again, day 15, you can see an improvement here with meibo in the total corneal fluorescein staining and the VAS dryness. And then you can see an improvement as well in the central fluorescein staining at day 57, and an improvement in burning and staining. So this is really helpful for our patients. Think about if a patient has central corneal staining, or really any corneal staining at all. It can significantly affect their vision with glasses, vision with contact lenses, vision after cataract surgery or refractive surgery, any sort of vision at all. It can really impact our patients. Now, fortunately, meibo is very well tolerated. So there were very, very few side effects, actually just very low discontinuation also in the studies. There were a few little side effects of blurred vision, conjunctival hyperemia. Here you can see again the meibo compared to the saline. The saline, there's actually more conjunctival hyperemia and more conjunctival papillae than the meibo group, but it's very safe, very effective. There were no changes in best corrected vision, slit lamp exam, IOP, and dilated fundus exam as well. So in both studies, there was improvement in the primary sign and the primary symptom endpoint. So this is quite unique and quite different, very well tolerated. And meibo is now the only prescription medication that can target excessive evaporation. So here you can see the cute little bottle. I think it's cute. And the bottle is a bit different because it is a single ingredient. It doesn't have any water in it. The drop size is very small. It does not contain any preservatives, therefore it does not have a pH, and it's steroid-free and safe to use. Meibo is safe to use with contact lens wearers, not with contact lenses on. Contact lenses do need to be inserted 30 minutes after meibo is used. So now, changing to the next topic, and we're going to talk about Demodex.
Numb, you can call that mental freeze. When these people talk too much, put that shit in slow motion. Yeah, I feel like an astronaut in the ocean. She say that I'm cool. I'm like, yeah, that's true. I believe in G-O-D. Don't believe in T-H-O-T. She keep playing me dumb. I'm a player for fools. Numb, you.
thanks to Laura Perriman, who graciously shared that video with me. We have to have a little bit of fun on a Wednesday night, right? So Demodex infestation is really underdiagnosed and undertreated. And I'm going to challenge all of you, just like you're going to start pushing on the lids, looking for meibomian gland dysfunction, even non-obvious meibomian gland dysfunction, to evaluate for Demodex blepharitis. Because once you start looking for it, you can't really unsee it. And you're going to see it so commonly in so many of your patients. Now, there's a significant symptom overlap with many different anterior segment conditions. And the mites, those little collarettes that you can see in this image here, you can see those cylindrical dandruff or collarettes, and that just equals Demodex. So anytime you see a collarette, the patient does have Demodex blepharitis. Now, there are two different types of Demodex. You have follicular, which is the larger type that resides at the base of the eyelashes, and brevis eats and loves those little meibomian glands and sebaceous glands. It's smaller in size. And both the mites you can see in that video earlier, there's another video coming later, have these little legs to grip onto a structure like an eyelash, and they stay on there. Now, what I learned when I was evaluating my patients for Demodex blepharitis and looking at every single patient, I encourage you to look at 10 patients. Look for meibomian gland dysfunction, look for blepharitis, look for Demodex, look for ptosis as well in your next 10 patients. And what surprised me about Demodex is that it's present in all age groups. I don't know about you, but when I was in school, we learned, oh yeah, it's in like 90-year-olds and you don't see it that much and whatever. But I, once looking at all sorts of patients, see it in teenagers, see it in people who are in their 50s, see it in 90-year-olds as well. It's really, really common. Now, what's very interesting is that there are different mechanisms of the disease. So there's this mechanical mechanism. And when you look at patients with Demodex, you can see that triangulation, or how their eyelashes are like in little triangles. And the mites deposit debris and digestive enzymes that cause irritation to the eyelid margin. Now, I always used to think of itch being allergy, and I now have learned that if I ask my patients about itch, they say, oh yes, my eyes itch. Now I ask them, where do your eyes itch? And oftentimes they'll say, oh, right here at the base of my eyelashes. And then I'm thinking Demodex and not necessarily allergy, although it could be both in combination. There's a bacterial component where these Demodex mites carry little bacteria on the exterior surface, and it causes this immune response, and it can be on the cornea as well. And then there could be a chemical component as well, with the debris of the mites that lead to the chronic inflammation and degeneration of the corneal and conjunctival tissue. So I would encourage you to look at the base of the lashes, because Demodex is correlated with all sorts of things. Blepharitis, any sorts of eyelid, eyelash alterations, like a lack of eyelashes, misdirection, triangulation of eyelashes, chronic conjunctivitis, really common, keratitis, and basal cell carcinoma as well. If there's a patient who comes in, they've had a history of dry eye, they've tried a lot of different things that haven't worked or haven't been effective, I would encourage you to evaluate for Demodex. And here you can see sort of the different mites, the different sizes of the mites. And there are many different symptoms. So I spoke about itching and asking your patients, where do your eyes itch? We can have patients who have symptoms of tearing, excessive tearing. Hyperemia is a really common one, which is why at the beginning, I like to look at my patients from across the room and just look to see if their eyes are red at all. And very interestingly, Demodex can be present in patients who are symptomatic and those who are not symptomatic at all. So they can be pretty asymptomatic or very symptomatic. I had a patient who kept going to the ER. This was during COVID. This was so awful because the Demodex mites were getting into his eye, and he'd go to the ER thinking he had some sort of foreign body in his eye. Fortunately, he's doing much better. I educated him not to go to the ER, but also his ocular surface is under much better control, and he hasn't had that happen again. Now, there's a poor correlation between symptoms and Demodex infestation. So here you can actually appreciate the collarettes. They're sort of translucent, they're solidified. They're very, very common and very present. So what we do is have our patients actually close their eyes or look down to look for the Demodex blepharitis mites. And here you can see, this is a really great image from Dr. Liz Yu of a patient looking in straight ahead gaze versus a patient looking down. So in straight ahead gaze, the base of their eyelashes look pretty okay, not too bad. But when the patient is looking down, looking at the base of the lashes, you can appreciate the Demodex. Now, I kind of go back and forth on having my patients close their eyes versus look down, and sometimes I'll have them do both. But in every single exam, and now I've been doing this for many years, I'll have the patients close their eyes. And the reason for doing this is I can look for other things as well. I can look for lagophthalmos, incomplete eyelid closure, see if there's any sort of space between their upper and lower lid. I can evaluate for floppy eyelids as well. And I can evaluate for Demodex. So there are many different things that can be seen when the eyes are closed completely. And so I would encourage you to do this. And oftentimes I'll have patients say, well, no one has ever had me close my eyes before. What are you doing? And I'll often talk about and say, I'm looking at your eyelids and lashes here. And one patient comes to mind of a man who was in his 50s, and he was in a bike accident many, many years ago, had a huge scar on his upper lid that looked great with his eyes open. And then with his eyes closed, I could obviously see it. And I asked him, have you ever had any eye surgery or eye injuries? What happened? And he told me about this bike accident. But he told me I was the first person who ever looked for this. But I would encourage you to do so, because you're going to learn a lot about the eyelids, which is going to help with the ocular surface, which is really going to help with everything else as well, whether it's contact lenses or glasses or refractive surgery, cataract surgery, any sort of surgery, because we do want to optimize that ocular surface. So here you can see there are many different comorbidities. So cataracts, 56% of patients who are going for cataract surgery have Demodex. Those who are on a prescription dry eye medication, 60% have Demodex, glaucoma, 65%, MGD, 57%, contact lens wearers, I'll talk about more about that in just a second, and facial rosacea, 60%. So very, very, very common in the majority of your patients, and the patients can be young and they can be older as well. So as many of you know, I do a lot of work in contact lenses, have a special interest. So I do want to share this because I think that this can really change. Two things can change to keep our patients in contact lenses. So now that we have a treatment for Demodex blepharitis and a treatment for meibomian gland dysfunction, just imagine the contact lens retention. We know that we have the best materials. I will say we have the best contact lens materials now. But we have many patients that drop out or discontinue contact lenses, approximately the same amount that are fit in contact lenses each year. And just think about how this can grow your practice, because not only do they need contact lenses, the exam and materials, but all contact lens wearers need glasses. Contact lens wearers need medical exams as well. So just bear with me for a second here. So Demodex and contact lens wear. So it could be that Demodex is one of the main culprits of infection. I'm going to throw you a few different studies. So here's one that found that Demodex was present in 90% of those who wear contact lenses, and compared to 65% of those who do not wear contact lenses. And it could be that contact lens wear provides a really advantageous environment for the little mites to proliferate. Same as blepharitis and meibomian gland dysfunction, where the mites get their food and they can proliferate. And the microorganisms have been found more frequently in those who wear contact lenses. So it could be that a contact lens offers a favorable environment for that excessive bacteria and could lead to more Demodex blepharitis. So here you can see the negative burden of Demodex blepharitis is real and very significant for our patients. So 80% of patients reported a negative impact on their daily life. Things like itchy eyes, dry eyes, foreign body sensation, like that patient I mentioned to you, watery eyes. And look at this. Many, many patients experience the signs and symptoms for more than 4 years. So these are patients that have gone from doctor to doctor to doctor. They have all sort of different symptoms. And what it really is Demodex blepharitis. And many of the patients were never diagnosed with blepharitis. And sometimes they made more than 6 appointments and 6 different visits to a doctor for this condition. So early identification of Demodex is really important for many, many patients with many different conditions. Now, I always like to focus on the quality of life for my patients. I want my patients to be happy and not thinking about their eyes. I want to make sure that their eyes are not bothersome in any way. And those with Demodex, 47% feel their eyes. I don't want my patients to feel their eyes at all. They're aware of them. Difficulty driving at night, I think, is really interesting. 47% of patients had difficulty driving at night, additional time needed for daily hygiene, a negative appearance of the eyes or eyelids, constantly worrying about the eyes and eyelids, and 34% of females had difficulty wearing makeup. That's a really big deal. I'm sure you have patients who came in and said, you know what, I used to be able to wear makeup and now I can't wear it anymore. And just be thinking, well, this could be Demodex. So fortunately, we now actually have a treatment for Demodex blepharitis. So X-Demv, again, brand new here in August 2023. It's a sterile, preserved, multi-dose, slightly yellowish topical ophthalmic solution. So it's a solution, it's a drop. And the active ingredient is lotilaner, 0.25%, and it's preserved with potassium sorbate. So here you can see the chemical name, which I'm not even going to try to pronounce, and the molecular formula. And this is really very unique because this new X-Demv actually serves as a non-competitive antagonist of mites, and it directly paralyzes the mite nervous system and through specific parasite-specific GABA inhibition leading to death. So it paralyzes mites, kills the mites, and it is a drop that is in a unique solution in a bottle. It's dosed twice daily for 6 weeks at a time. So this is actually the first treatment that is done, and you can see that there were different clinical studies, Saturn 1 and Saturn 2. I'm going to dive into the data a little bit here. And I really like pictures. So here you can see the grading from the studies of the Demodex mites. So you can appreciate on the left, the grade 4, more than 2 to 3 lashes on the lids had collarettes, all the way down to grade 2, between 10 collarettes to 1/3 of lashes, down to grade 1, which is 3 to 10 collarettes, and 0 to 2 collarettes on the lashes. This was the FDA primary endpoint, was complete cure of the collarettes. Eyelid or erythema scale, here you can see this too. So again, looking at your patient from across the room, actually evaluating their eyelids, seeing how red they are. You can appreciate the severe, moderate, mild, and no erythema on the eyelids. And here you can see the baseline characteristics of the studies. So the TPO3, which is now the X-Demv, compared to the vehicle, we have similar ages in both studies. You can see the proportion of male and female, very similar as well. The collarette scores, the mites per lash, and the erythema score as well. And up top, you can see the number of patients in both studies is very similar as well. So the primary endpoint of complete collarette cure. So this is less than or equal to 2 collarettes, again, a few slides back. And it was achieved, and here you can look again, the XDEMV, which is the grayish, yellowish color here compared to the vehicle, the bluish color. The primary endpoint at day 43, you can see the collarette cure was very significant in both studies here. And looking back to all the different collarettes and the number of collarettes having basically no collarettes is, in my mind, absolutely amazing. However, this was statistically significant, clinical, meaningful collarette cure in the TP03 group compared to the vehicle, even at week 2. Again, the TP03 is XDEMV now. The secondary endpoint of mite eradication, so 0 mites are all gone, and looking, there was a statistically significant mite eradication, again at week 2. So that is actually very, very fast after 2 weeks that all of the mites are actually gone. So the secondary endpoint here, the erythema, the eyelid redness, at day 43, again, statistically significant. So looking at the adverse events, there were very few adverse events. You can see there were a few here. So installation site pain, burning, stinging. You can see a little bit of eye pain in both groups for both. So looking at both groups here on the left, eye pain, there was minimal eye pain in Saturn II on the right, and all adverse events were very mild or moderate in both studies. So most patients in the study said that the drops were very comfortable. They were neutral to very comfortable, and the high comfort level was experienced by patients in both studies. So here you can see the XDEMV bottle. It's a sterile ophthalmic solution. So again, it's an eye drop for Demodex blepharitis. It's a 10 ml bottle. It has it actually can be used until it expires. And it has a special multiple dose bottle with a low density polyethylene bottle. Again, I need to practice all this because all of this is so brand new. So when we're talking to patients, how do we talk to them about it? Handling the container like any other drop. Don't touch the tip of the container to your eye. Don't use with contact lenses. And if you miss a dose, talk to your physician. Using with other ophthalmic medications, waiting at least 5 minutes between them. And if you miss a dose, continue with the next dose. So let's watch this fun video on Demodex. I like how the mites were paralyzed there. Thanks to Tarsus for this nice video. So key takeaways, Demodex blepharitis is really common in many patients who have blepharitis, who have dry eye, in patients who are not able to wear makeup, in patients that might have contact lens discomfort or discontinue contact lenses. And XDEMV might be a very safe and effective treatment for Demodex blepharitis. And it's a very comfortable option. So again, just coming very, very soon. So now moving on to digital device use, which is incredibly common, just touching on this really quickly as a reminder that when we're on digital devices, we don't blink as much as when we're not on digital devices. So actually about 5 times less. And the blink rate is decreased significantly when reading a book and electronic tablet compared to non-reading tasks. So we're all on digital devices. There's a global dependence on digital devices. Digital devices are associated with all sorts of eye complaints, eye strain, dryness, burning, blurry vision, irritation, and dry eye has been demonstrated in many different studies. Digital device use is also associated with meibomian gland dysfunction and tasks that have an increased cognitive demand, so where you have to pay attention a little bit more to these tasks, have a decreased blink rate. So this was a study looking at those tasks with a high cognitive demand compared to a low cognitive demand. And that task difficulty really was associated with the blink rate in those with dry eye disease. So we all know the 20-20-20 rule. And this is something that I feel like I say so many times every single day. But just a reminder, they're really great graphics that are available all over the place that you can use. We use them in our clinic. And we know that every 20 seconds, we want to look, or every 20 minutes, we want to look 20 feet away for 20 seconds and take a break, blink your eyes, get up, walk around, go outside would be great. Every 20 minutes, we don't want to be looking at another digital device. We want to be out in nature, I think would be wonderful. We also know that it's very important how we sit in front of computers and digital devices. We want to look down about 10 degrees. We can talk to our patients about blinking exercises, their apps, if you want to share that with your patients. Desktop humidifiers are quite helpful. Lubricating our eyes as well during the day is very helpful as well. Here are some examples of blink exercises that you can use. And I think that the little humidifiers, they are very cute, but there have been studies that show by adding a humidifier is very helpful. And so my patients who have severe dry eye, like Sjogren's, they find that this is very helpful to have both a humidifier at home and at work, especially in different time of year, say if it's in the wintertime with the heater, or if it's in the summertime with an air. Of course, with the air conditioner, we want to avoid any overhead ceiling fans in general. I am only bringing up mask-associated dry eye because I'm sure all of you have heard all about this, where the hot air blows up into the eyes and causes ocular dryness. But this is just some helpful resources that are available in multiple languages. If you want, you can share it with your patients in your practices. And we can tape the mask, we can lubricate with eye drops. Here in California, there are people now wearing masks more than they were even 2 months ago. And hydrate, are drinking water, and that 20-20-20 rule. So moving on, and the next topic here is ptosis. So this is kind of a neat video. So you can see this is a mother and daughter, and you can see the still image there, and then you can see them blinking. And when we're evaluating for ptosis, we're looking at the eyelid position, and we're seeing where does that eyelid sit, and we can actually measure it from the center of the pupil. I really like that video. And in ptosis, which can be congenital or acquired, it's that low lying or drooping, and I never ever like to say drooping to my patients, upper eyelid margin with the eye in primary gaze. So I just have my patients look straight ahead in primary gaze to evaluate the position of their eyelids. The severity of ptosis depends on the degree of the low-lying eyelid, and it can be unilateral or bilateral. It can be asymmetric bilateral as well. Now, ptosis can affect, and here you can see at the bottom of my slides, there are all the references to these studies, because I think it's really interesting that there are studies on all of these topics. But ptosis can really affect everyone's function. So by obstructing the pupil, it can cause superior visual field defects, It can affect falls as well. It can affect contrast sensitivity and dry eye disease, and of course, cosmesis. So that sleepy look where patients come in, they say, oh, everyone's telling me that I look tired, but I'm not tired, or there's asymmetry, or I have patients who say, my eyelids don't look like they used to. And the way that I like to think about acquired ptosis and not congenital, but acquired ptosis is like presbyopia. Our eyelid position definitely changes with time. I never like to say as you get older or anything like that, but it does change with time. So here you can see, and I'm going to talk mostly here about acquired ptosis because it's a result of the stretching of that levator muscle or disinsertion of the levator muscle complex. And it can be due to reduced nervous input on the upper eyelid. It can be due to injury. It could be a mechanical cause or a myogenic cause, primary muscle dysfunction, and congenital ptosis also can occur as well. So with time, with aging, again, I never like to say aging, but over time, we can say that the upper lids really change and they get lower. And oftentimes I'll ask my patients to determine if this is something that's new or something that's longstanding, is just to show old pictures. Pull out any pictures on their phone of many years ago is very helpful, or to pull up pictures and share pictures from when they were a child. So ptosis is incredibly prevalent. Again, I think that these numbers are pretty low, but at least 13 million people who are 50 or older in 2020 had ptosis, 1 in 10 adults. Again, I think it's pretty low. And there are many different risk factors. So 1 is aging, 2 is contact lens wear, and not just our corneal gas permeable lenses where we're pulling on the outside of the eyelid. Ptosis has been associated with soft contact lens wear as well. Any sort of ocular surgery, so think of a lid speculum to open the eye for any type of surgery, cataract surgery, corneal transplantation, any sort of underlying disease, Botox or other neurotoxin injections, or trauma. So many different risk factors for ptosis. Now, I know that all of you know this because you are skilled eye care practitioners, but we know that if it's a sudden new onset of ptosis, that's a very huge concern. So it can be a very serious, urgent workup, same day, urgent. If it's an underlying neurological disease, so if ptosis is associated with Horner syndrome, we can have that ipsilateral pupil constriction, eye redness, and that lack of sensation or on the face as well. Myasthenia gravis is something that we definitely need to work up. CPEO again, or any sort of ocular motor nerve palsy, we need to evaluate urgently. But for non-urgent cases that are acquired, we can measure the MRD1, which is the marginal reflex distance 1, the distance between the center of the pupillary light reflex and the upper eyelid margin. Normal is about 4 to 5 millimeters. We can look for levator muscle function, so have our patients look down and up, and normal is greater than 15. The eyelid crease height, the distance between the upper eyelid margin and the eyelid crease, normal in males is 7 to 8 millimeters, 9 to 10 in females. And of course, we can perform visual field testing as well. But ptosis really impacts our patients' wellness and vision, not only the cosmetic. I think the cosmetic is kind of the straightforward one, but the psychological, so anxiety and depression is not as straightforward as cosmesis. But patients, and there have been studies to show this, but patients who have ptosis are very affected by anxiety and depression. And actually, during COVID, when we were all on Zoom, like we are right now, there have been more surgeries done just in general, right? Surgeries for eyelids, but for the face as well, because people are looking at themselves like they never did before. We know that ptosis impacts blurry vision, higher order aberrations, and all sorts of visual tasks, especially digital device use, any sort of reading. And then if we're trying to open our eyes And say you have a patient who's in a progressive lens looking at a monitor and is in a funny sort of position, it can affect neck pain, brow ache, headaches, and eye strain as well. So before we actually had this product, we could diagnose ptosis, but unless it was kind of severe, moderate to severe, and we're sending the patient on for surgery, oftentimes we didn't really diagnose it. But now that we have Upneeq, which is a very unique product, and when I prescribe it, my patients say, "How does it work?" And I say, "It works like magic." And they're like, "No." And I say, "Actually not. No, it actually is a direct acting alpha adrenergic receptor agonist that has a 5-fold greater affinity for those alpha 2 receptors. So it actually works on the eyelid to pull the eyelid up, to lift it up, and it targets the receptors in Mueller's muscle. So in your patients who have mild to moderate ptosis, this could be an option for them. And what I found with my patients is even those who have a little bit of asymmetry, those who want a more open-eyed look, have found a lot of benefits. And it's not just women, it's also men who have ptosis. I love prescribing Upneeq for my 80-year-old patients, my 90-year-old patients who don't want to have any sort of eyelid surgery. And I've been very impressed with even the severe ptosis cases where Upneeq works really well. And patients are saying things like, "This is life-changing. I can't believe how much this helps." And it can be used, the drop can be used 1 drop each eye daily, or it can be used just as needed on certain days. So if there's a social function or a special Zoom meeting or whatever it might be, I'll have patients use it. But it's been a very unique product that has been recognized not only by eye care practitioners, but by others as well. So here you can see 2 different uses of Upneeq. And what I like to do is put the drop in, take a photo, have the patient look straight ahead, and then about 15 minutes later, take another photo and have them look straight. You can see in the pictures on the left here, they're not exactly straight ahead, but you can sort of get the idea. But that's very helpful to talk to our patients and to see if this is something that is working for them. And it has been recognized in many different outlets out there as well, especially now in the last few months. You might have seen it more so than before. So you might have patients asking you about it. So what are we going to do with all this information to optimize the ocular surface to ensure success? Well, the good news is that now we're going to evaluate the meibomian glands. And we're going to evaluate, even if you don't have any fancy instrumentation, you can use a transilluminator to evaluate the meibomian glands. I would encourage you to push or press on the meibomian glands as well. If you do have meibography, that's fantastic. And we want to look at the meibomian glands for any sort of atrophy. And we can express meibomian glands as well. So, and grade that expression. So here you can see the transilluminator used to look for lagophthalmos and gland atrophy. Again, you don't need a meibography if you don't have it. You can also use that handy transilluminator to look for that incomplete eyelid closure. And this is the Korb-Blackie lid light evaluation, looking at a study here that many patients who report dryness when they wake up in the morning actually have incomplete eyelid seal. So just take out that transilluminator. We have many different management techniques, and due to time, I'm not going over all of them, but we can prescribe or recommend different commercial warm compresses, different sorts of eyelid hygiene. This is a study that shows that by using a warm compress 10 minutes once a day, it improves comfortable contact lens wearing time, which is like, I like to share this study with my patients to try and get them to actually be compliant and to improve their comfortable contact lens wearing time. And of course, we have many different alternative technologies, and which is a very exciting time. And we can use the technologies in combination that can really help our patients as well. So whatever action plan we have, it should really address both inflammation and obstruction. So we can use something to remove obstruction and then work on inflammation, like some of the products that I spoke about tonight. Now, 87% believe that obstruction is actually a key component of meibomian gland dysfunction. 71% state that obstruction removal should be the first line treatment for patients with MGD, yet only 5% of patients receive thermal expression treatment. So I would encourage you, hopefully, to, once you're evaluating the eyelids, once you're looking for obstruction, to actually use one of these technologies to really help your patients. This was a study that looked at tear care compared to LipiFlow, and tear care improved the quality of vision and overall dry eye symptom frequency and here you can see the difference between tear care and LipiFlow, so it is effective. We have different oral medication options, and this study that was a review, the take-home point is that there was insufficient evidence to draw any meaningful conclusions on the use of oral antibiotics for chronic blepharitis. And this is, again, just very interesting. This was another review in the ocular surface saying that patients with blepharitis or MGD-related dry eye have short-term benefits of antibiotics, but evidence for lasting improvement after completing treatment is lacking. Now, fortunately, we do have oral dietary supplements that are helpful, especially those that contain GLA, because GLA improves markers of inflammation in those with dry eye in many different types of patients, including those with Sjogren's. And we have to talk to our patients about what they're using, all the products that they're using. We can recommend different types of products that are helpful for the ocular surface. There are daytime and nighttime moisture release goggles. We also have Sleep Tight, Sleep Right, which patients can use at nighttime to help with the lagophthalmos and incomplete closure. IPL as well, and I know we're almost out of time here. We have radio frequency, again, that we can use in combination, LLLT, and the future is coming soon, and that is looking at the microbiome and ocular health. And there's a significant correlation with the gut microbiome and in all sorts of health and ocular and disease. But now I hope that we will have some products coming soon that help with ocular disease as well. So with that, I really do want to thank you